GI pathology, colonic polyps, as well as colorectal cancer. All right, so for colonic polyps, what they want you to know first and foremost is that the most common type of polyp that they're going to see that's usually non-neoplastic, so not usually associated with cancer, is going to be the hyperplastic polyps, okay? Hyperplastic polyps. And what they will say is that occasionally evolves into serrated polyps, okay? And these are more advanced lesions. They're like sawtooth, but hyperplastic polyps are the most common, which are generally non-neoplastic, all right? You also have hamartomatous polyps. These are associated with Peutz-Jeghers syndrome and juvenile polyposis, which we'll discuss in a second. All right. Now, for the potentially malignant polyps, what you need to know is the adenomatous polyps. Okay. For adenomatous polyps, these are neoplastic. Okay, and they're associated with mutations in the APC and KRAS. So, tubular histology of adenomatous polyps are less malignant compared to villus histology. So if you see villus histology of adenomatous polyps, then you know that it's the highest risk of malignancy, okay? So they say villus histology is villainous, all right? That's how they remember it, all right? Adenomatous polyps are potentially malignant because it can have a villus histology, all right? So that's pretty much our colonic polyps that you need to know. Now, there's polyposis syndromes, okay? So syndromes that are associated with multiple polyps. The first one and the highest yield one for you to know is FAP, okay? Familial adenomatous polyposis, FAP. It's an autosomal dominant mutation of APC tumor suppressor gene. Very high yield to know that, okay? And you're gonna see thousands of polyps, okay? Thousands of polyps starting after puberty. And it always involves the rectum. What they want you to know is that you have to do a prophylactic colectomy, or else it 100% of the time will progress to colorectal cancer. So you have to take out the colon in order to save them from getting colorectal cancer. It's 100% progression to colorectal cancer, and that's a question they like to ask for FAP. So remember, FAP is autosomal dominant mutation of the APC tumor suppressor gene, and it's thousands of polyps involving the rectum, and you have to do a prophylactic colectomy because it's 100% progresses to CRC, colorectal cancer. Next is Gardner syndrome, which is just FAP, which we just discussed, with some type of bone disease, bone abnormality. So osseous or soft tissue tumor. All right, that's how I remember it. Turcot syndrome is FAP with some type of malignant CNS tumor, okay, cranial nerve tumor, or central nervous system tumor, sorry. Peutz-Jeghers syndrome, this is important. What they will say is that there's numerous hamartomatous polyps, so that's why you need to know hamartomatous is for Peutz-Jeghers syndrome throughout the GI tract, and you're going to see hyperpigmented macules around the mouth, lips, hands, and genitals. Okay, so you're going to see these blue things on the lips and palms. That's telling you that it's Peutz-Jeghers. Okay, very important to know that. You'll see an increased risk of breast and GI cancers associated with Peutz-Jeghers. Okay, so if you see hyperpigmented macules and hamartomatous polyps, then you know it's Peutz-Jeghers. Remember, the hyperpigmented macules are going to be like these blue little dots or blue things on the lips and the palms. All right. Now, next, we're going to talk about Lynch syndrome. Lynch syndrome is also called HNPCC, hereditary non-polyposis colorectal cancer. All right. It's an autosomal dominant mutation of the mismatch repair genes. I don't know if you remember learning about it in your M1 courses, but this is your mismatch genes. Okay. MSH2, MLH1. These are mutations of the mismatch repair genes for DNA. Okay, and it causes HNPCC or Lynch syndrome. So what does that mean? It causes this HPNCC and it progresses to colorectal cancer. Okay, so you're going to have proximal colon usually always involved, and it's going to be associated with other cancers as well. Endometrial cancer, ovarian cancer, and skin cancers. So if you see a patient with familial history that they have endometrial, ovarian, and skin cancers throughout their family, and now they're presenting with signs and symptoms of CRC, colorectal cancer, then you know that it's potentially talking about Lynch syndrome, okay, or HNPCC. It's the same thing. And they could ask you, it's a mutation to what? It's going to be the mismatch repair genes. Okay, so think about it that way. So now let's finally talk about colorectal cancer. So first and foremost, what you need to learn for colorectal cancer is that most patients are greater than 50 years old, okay? Greater than 50 years old is going to be colorectal cancers. And the risk factors associated are adenomatous polyps and serrated polyps, right, as we discussed, some type of familial cancer history or syndromes like Lynch syndrome, inflammatory bowel diseases increase your risk for colorectal cancer, and then any diet that's like processed meats or low fiber can also increase your risk of colorectal cancer, okay? Now, overall, the presentation, the most commonly involved area of the colon for colorectal cancer is going to be your rectosigmoid colon, then ascending colon, and then finally descending colon. All right. So you have to separate out between colorectal cancer that's occurring at the ascending colon versus occurring at the descending colon. And they call this ascending is going to be like your cecal and ascending is going to be your right-sided colorectal cancers, and your descending is usually going to be your left-sided colorectal cancer. So don't get rattled. Right-sided cancer and left-sided cancer just means ascending cancer and descending cancer, respectively, okay? So let's start. First thing you need to know is the difference between ascending cancer and descending cancer, or right-sided cancer versus left-sided cancer. So right-sided cancer, think about your body. What's on the right side? Your cecal area, right? The cecal portion of the bowel and the ascending bowel, right? On the left side, what's on the left side? It's going to be your descending bowel as well as the rectosigmoidal bowel, okay? So this is how we separate them up, is the right-sided or ascending and then left-sided or descending. So this is very clear and straightforward for colorectal cancer. If you see a patient with a large, bulky mass, okay, and they have occult bleeding, which leads to iron deficiency anemia and weight loss, then that's a right-sided mass, right-sided colorectal cancer or ascending colorectal cancer, okay? So let's take each one of those. So the right-sided cancers are more likely to present as a large, bulky mass, and they're more likely to bleed but have microscopic bleeding, which is known as occult bleeding, okay? So you're not going to see gross hematochezia in your stool. You're not going to see gross blood in the stool. It's going to be microscopic, so you're not going to be able to catch it unless you actually order an occult blood test, okay? A fecal occult blood test. So since that bleeding is occult and you're not able to see it, it leads to iron deficiency anemia, all right? And so iron deficiency anemia along with occult bleeding is more common on the right side or ascending cancers. For the descending and left-sided cancers, they usually are going to encircle the colon, okay? So it's going to cause narrowing of the lumen. It's not going to cause like a large mass in the lumen. So since it causes encircling of the colon and narrowing of the lumen, you're going to see altered bowel habits. So you could have like decrease in the stool caliber. It could be like pencil-like stools. You also are going to present with bloody stools, frank hematochezia, okay? You also could see obstructive symptoms and colicky pain. Okay, that's the key difference between descending and left-sided versus ascending and right-sided, all right? Now, before we move on, I want to discuss kind of the screening mechanisms. Average risk patients, you're going to screen them at age 45 with colonoscopy. They should get a colonoscopy at age 45, okay? And they should get like fecal occult blood testing is very helpful as well. Now, patients with IBD, inflammatory bowel disease, they should get screened 8 years after the onset of their IBD diagnosis. And lastly, what you need to know for tumor marker-wise is for colorectal cancer has CEA as its tumor marker. But CEA is not used for diagnosing or screening. It's only good for monitoring recurrence or residual disease. And that's very important to know. Okay, last thing about colorectal cancer is that if the tumor cells are in the regional lymph nodes, I mean, it's very obvious, but if they reach regional lymph nodes, that's a poor prognosis because that means that they have an increased risk or potential to metastasize. So lastly, at the end of the day for colorectal cancer, we have to talk about the molecular pathogenesis in which it occurs. So there's two types of pathways. The first pathway is the chromosomal instability pathway. What happens first is that you lose APC. Okay, so you have the loss of APC gene. And so that puts the colon at risk. Okay. Then if you have a KRAS mutation, that leads to an adenoma formation. And then after an adenoma forms, if you have loss of tumor suppressor genes like TP53 and DCC, then it leads to tumor genesis and carcinoma. So that's the chromosomal instability pathway, okay? Very important to know. Now, for the other hand, you have microsatellite instability pathway, which is just mutations or methylation of the mismatch repair genes, right? And this is what causes the Lynch syndrome. So this is kind of the abnormalities in colorectal cancer, the Lynch syndrome patients, okay? Majority of patients with colorectal cancer are going to have the chromosomal instability pathway. This is what normally happens in patients. You first have the loss of APC gene, then KRAS mutation, followed by the loss of tumor suppressor genes like TP53. Okay, so they want you to know that process for chromosomal instability pathway. The microsatellite pathway is just mutations or methylation of mismatch repair genes seen in Lynch syndrome. All right. Lastly, overexpression of COX-2 has been linked to colorectal cancer. So that means any medication that blocks or inhibits COX-2 can be chemoprotective. So patients that are given NSAIDs may have some type of protection. All right. So patients that take NSAIDs can have some protection from colorectal cancer because in colorectal cancer it has been linked to overexpression of COX-2. All right. So that's all for colorectal cancer, our colonic polyps, and our polyposis syndromes. If you have any questions, please reach out.